through the process where the anticipated identification of those who may have a problem and who might benefit from further investigation and treatment. So, and also WHO defines few guidelines for what all should we do screening for. So the condition should be an important public health problem. There should be an accepted treatment. Facilities for diagnosis and treatment should be available. There should be a suitable test. It should be acceptable to the problem. The natural history of the disease should be adequately understood so that we can intervene. There should be agreed policies. The cost should be good enough so that it doesn't offset the balance of screening. And also case finding should be a continuous process, not just an ad hoc thing. And these make even more sense when you're talking about childhood eye disease. But looking at some of these definitions, childhood eye screening all programs may not fall into the precise definition of screening, because in a lot of these cases the disease or the pathology or the condition has already occurred. We're just trying to detect it early and try to intervene. So we can actually imply case finding or case detection when we look at these terms. So what all can we screen for children? So basically based on age groups, we can screen children for a lot of diseases. In fact, premature infants, we can definitely screen them for retinopathy of prematurity. Perinatal period for congenital cataracts, other anterior segment pathologies, glaucoma. Preschool children can be screened for amblyopia, strabismus, and anisometropia, other uncorrected refractive errors. And also school-grade children can be looked at, higher uncorrected refractive errors that are causing blurry vision and others. Also, incidental detection of congenital anomalies can happen at any level. But why screen for childhood visual impairment? We will be hearing from other authors regarding the magnitude of the disease, so I'm not giving those numbers here. Dr. Taranum will give you those numbers, which are pretty alarming. But we know that Vision 2020 does consider it as an important public health issue. Children, in terms of blind years, childhood blindness is the second largest cause of disability life years, just after cataract, which is more in numbers. So we know that a child with blindness has to live a lot of years. So that blind year component is much more than adults. Also, it's not about just the health of the child. The vision of the child is also linked to the overall development of not just the child, but also has an impact on the overall society. In terms of the development goals, it affects the under 5 years child survival rate. We know that children with significant visual impairment have considerably reduced longevity. Education, good vision, perfect eyesight is definitely a contributor to good education. And also in terms of overall intellectual development, employability, good visual acuity is also essential. So it goes a long way in poverty elevation. So looking at this, childhood blindness definitely qualifies for putting efforts in early detection and providing good treatment modalities and adequate management overall. But what are the challenges? It's not exactly as the adult screening, because there's definitely low prevalence relative to adult programs. So when we look at an adult blindness program, the prevalence thumb rule may be 1% of the population, whereas in children it is much lower. It's sometimes as low as 0.8 in per thousand. So you need to screen a very large number if you go the conventional method of screening all children. Lack of awareness definitely is an issue, because in most of the areas, parents are not aware of what the possible issues may be. And not just the parents, sometimes the healthcare providers, be it pediatricians, be it the primary health physicians, even sometimes general ophthalmologists are usually not fully aware of what are the conditions that a child may have. So consequently, what all should be done. Also, the skill required to screen children is definitely more than that required for screening just refractive errors in adults or even a simple cataract. So you need highly skilled manpower, which definitely is a limitation. There is a social stigma attached to children with blindness or any ocular anomaly as such. So a lot of these may not be forthcoming to bring the child to a suitable location where he or she can be screened, particularly the female child who, if is blind or has an ocular deformity, would rather be kept isolated and not brought forward than be detected early. Lack of service provider for providing affordable treatment, because although tertiary care in India has bloomed a lot and pediatric ophthalmology is one of the specialties that's taking leaps and bounds, but having a service which is affordable and accessible to communities which may not be essentially affording it is challenge. So what is the ideal case finding methodology for childhood blindness? As for any other, low cost and high yield. It needs to be cost effective. So per unit cost of acquisition of